Chapter 20 concerns infectious diseases of the cardiovascular and lymphatic systems. We are focusing only on diseases of the lymphatic system. So first, these two systems are both systemic, meaning they extend to all parts of the body. The cardiovascular system is the system whereby blood is oxygenated and delivered to all extremities of the body. The lymphatic system largely mirrors the cardiovascular system in its organization. The purpose of the lymphatic system is to filter liquid that exits the blood and enters the tissues. And when it filters this liquid, it removes any infectious agents or contaminants, and then the liquid portion that has been filtered is returned to the cardiovascular system. So both the cardiovascular and lymphatic systems are closed systems. They're really protected from contact with the outside, but they both work together. So the cardiovascular and lymphatic systems are associated with one another. The reason that these systems are closed and really protected from outside invaders is that if a microbe gets into the blood, it will immediately have access to all parts of the body because the blood is circulating throughout the body. So any microbe that gets into the cardiovascular system will immediately cause a systemic infection, which is challenging for the immune system to deal with. We do have immune presence in both the cardiovascular and lymphatic systems. The bulk of this is in the lymphatic system, where we have a really big concentration of immune defenses in the lymph nodes, which are concentrated areas of the lymphatic tissue along the groin, in the armpits, and at the neck. And these areas are called the lymph nodes. So we have quite a lot of lymphocytes, both B and T cells, and we have phagocytes. So we have presence of second and third lines of defense in the lymphatic system. Okay, the first disease we're going to discuss is Yersinia pestis. So this is a disease of the lymphatic system. It is caused by this bacteria, which is a gram-negative rod. The diseases that it causes are the plague. So we'll talk about three outcomes of plague: bubonic, pneumonic, and septicemia plague. So generally, this bacteria is found in different types of mammals. So there are rats, ground squirrels, and prairie dogs being the most common reservoir of Yersinia pestis. Mortality rates for plague are about 15% within 2 to 4 days, even with treatment. So when this disease is contracted by a person, it's very serious and medical attention is needed immediately in order to prevent mortality, which is very likely. It is still endemic in some parts of the world, in Africa and parts of the Soviet Union, and we have it occurring sporadically in the southwest areas of the United States, specifically the Four Corners region. So the modes of transmission are by direct contact with body fluids. So if a person has bubonic plague and they have fluids that come into contact with another, the plague can be transmitted this way. It can be transmitted by a biological vector. So the vector for Y. pestis is the flea. And this flea can bite a person with plague and carry the bacteria in their body and then bite a second person to transmit plague from person to person. And then when the growth of Yersinia pestis occurs in the lungs in pneumonic plague, we can have transmission by simple respiratory droplets, so directly from person to person without a vector in between. So for virulence factors, the Yersinia pestis is excellent at infecting humans, so you need a very small number of bacteria in order to cause infection. It has a capsule, and it also makes plasminogen activator, which causes blood clotting and allows Yersinia pestis to evade phagocytosis. Tissues infected are the lower respiratory tract in pneumonic plague, the lymph nodes in bubonic and pneumonic plague, and the blood, lymph node, and lower respiratory tract in septicemia plague. Signs and symptoms are buboes, which I'll show you a picture of in the next slide. This is an inflamed lymph node that looks like a mass on the surface of the skin. You have fever, chills, headache, nausea, and weakness. Diagnosis is rapid genomic method, so you would test for the presence of Yersinia pestis DNA, and these can be read immediately, so this helps with the haste that's needed in treating Yersinia pestis. You have to identify it really quickly. Rapid genomic methods are usually confirmed with bacteria culture, so you would also do a culture of a patient swab, gram stain, and then you'd look for the presence of the gram-negative rod. And I'll show you a picture of what that looks like as well. Prevention and treatment is antibiotics. So often if plague is suspected, antibiotics will be started, and then we'll wait for bacteria culture to confirm. Okay, so on the left, in Figure 20.4 Part A, we have a picture of a bubo. So this is an individual infected with Yersinia pestis, and we have the inflammation of lymph nodes at the groin. On the right, in Part B, we have a gram stain of lymph fluid, and Yersinia pestis is indicated with the line. It's often described as being safety pin in appearance because one of the ends of the rods, or the ends of the rods, stain more strongly than the interior. So you'll have a rod with darker pink ends, and then the interior will be lighter pink because it's a gram-negative. Okay, 3 outcomes of Yersinia pestis infection. So this figure kind of shows how Y. pestis is transmitted from host to host, and then we'll also discuss what happens as a result of this infection. So first, on the left of figure 20.6, we have listed the endemic reservoir hosts. So these are mammals that normally carry Y. pestis in their person, and the presence of Y. pestis does not make them sick. In the middle, we have amplifying hosts, which are mammals that when they have Y. pestis in their person, they will be sickened and they'll die. So when there's outbreaks of Y. pestis, we can see massive die-offs of chipmunks, ground squirrels. In between the endemic and amplifying hosts is the flea. So if a flea bites an infected mammal, the Y. pestis then gets into the flea, and the Y. pestis causes coagulation in the throat of the flea so that it can't get blood to its stomach for nourishment. So the flea becomes really famished and starts biting crazy. So it helps spread Y. pestis from host to host. If the flea bites an endemic or an amplifying host that's infected with Y. pestis and then bites a human, the human will then be infected with the bacteria. So in the first outcome of Y. pestis infection is bubonic plague, where the Y. pestis is growing in the lymph tissue, and we can see development of buboes as a result of that. If the bacteria spreads to the lungs, we then have pneumonic plague. So the bacteria is not only growing in lymphatic tissue, but it can also spread to respiratory tissue. When a person has pneumonic plague, their respiratory droplets are now infected with the bacteria. So in cases of pneumonic plague, we can spread from individual to individual through respiratory droplets, where bubonic plague would have to be spread through the flea vector. And then when growth of Y. pestis becomes even more severe in the person, we can see septicemia plague, which is massive growth of Yersinia pestis in the blood. And this results in inflammation of the lymph vessels, which in this individual, we have an inflamed lymph vessel under their arm, which is causing redness even on the surface. We also can have septic shock, which would be the presence of Yersinia pestis in the blood. And this is a very dangerous condition that leads to reduction in blood pressure and can cause multi-organ failure. And then we have endotoxic shock, which is the release of LPS from the gram-negative Yersinia pestis, which causes a massive immune response and can make the host very sick. So septicemia plague is the most difficult with the lowest percent survival if a person develops this type of plague. Okay, the next lymphatic disease is Epstein-Barr virus. So this is a member of the herpes viridae family, so it's a herpes virus. It's herpes virus 4, which we can abbreviate human herpes virus 4 or HHV4. It has a really long incubation period, so you're exposed, and then 30 to 50 days later you can develop signs of infection. And the Epstein-Barr virus infection is chronic, so if you're ever infected through your life, you will have Epstein-Barr virus in your body chronically, and it's estimated that 90% of the world is infected, so it's very, very common. Diseases caused most commonly is mononucleosis, which is usually referred to as mono or the kissing disease. In very rare cases, it can develop into oral hairy leukoplakia or Burkitt's lymphoma, which is a type of blood cancer, and I'll show you both of those in just a moment. The mode of transmission for Epstein-Barr virus is direct contact with saliva, blood, or body fluids, most commonly via saliva. So there's quite a lot of virus particles in the saliva in an infected person, which is why it's most commonly transmitted by kissing or saliva exchange. Virulence factors, so we have latency, so it goes through periods of inactivity but remains in the host. It also has ability to splice viral RNA into the host cell DNA as a provirus. So in this way, it can remain in the host cells without causing any signs or symptoms. It infects B lymphocytes, and it will suppress their ability to undergo apoptosis. So even if the B lymphocyte presents antigen on MHC1 to a cytotoxic T cell, if it gets infected, the cytotoxic T cell would send a signal for the infected B lymphocyte to undergo apoptosis, but Epstein-Barr is able to suppress this signal. So the infected B lymphocyte, although it presents antigen, is not destroyed, and the Epstein-Barr virus persists. It's also able to avoid phagocytosis by preventing lysosome formation. That's a typo there, I'll fix. And so it gets into the phagocyte but is not destroyed. It is a systemic infection. There's quite a lot of signs and symptoms associated with it. And diagnosis is usually by a blood cell count. So if the number of lymphocytes is reduced in the blood, it can be an indicator of Epstein-Barr infection. We also can look for monocytes with lobular nuclei, which I'll show you in just a moment. And then there is a test for antibodies in the host against Epstein-Barr virus. If the host is attempting to fight the infection, we can detect this by measuring antibodies. Prevention and treatment is just alleviation of symptoms. You're often very fatigued, so you have to avoid strenuous activity to avoid injuring your enlarged spleen or liver, and just rest until the symptoms pass. So this is what a atypical lymphocyte that's infected with Epstein-Barr virus looks like. So taking a blood sample and doing a blood smear, looking at it under the microscope can indicate the presence of lymphocytes infected with Epstein-Barr. And then this slide shows the outcomes of Epstein-Barr virus infection. So the time of infection is very telling of what the outcome will be. In teenagers through adults, if you get infected with Epstein-Barr virus for the first time, you will develop mono. And most of the symptoms of mono are because you have a very vigorous cellular immune response. So your cytotoxic T cells respond to the virus infection, and the response of those T cells actually are a lot of the signs and symptoms of mono. If a toddler gets exposed to Epstein-Barr virus, it's probably going to be an asymptomatic infection that you'll never know. And then the other two cases, oral hairy leukoplakia and Burkitt's lymphoma, are examples of very, very rare cases of Epstein-Barr virus infection where the individual has a very poor or lacking immune system, either because they're infected with HIV or malaria or some other disease that's occupying a lot of their immune cells. So in these two cases, we have this really rare oral hairy leukoplakia, which is sores on the mouth, and then Burkitt's lymphoma. And these other things listed are types of blood cancers. So in both of these cases, you can treat the disease by treating the signs and symptoms. Okay, and then the last lymphatic disease is human immunodeficiency virus, or HIV. So this is a RNA retrovirus, so it has an RNA genome. It is also covered in an envelope outside of its capsid. It first emerged in the United States in the 1980s. It's estimated that 60 million are infected in the world and that 30 million people have died. 45% of those infected worldwide don't know it. In the United States, it's estimated that 14% of those infected are unaware. And 1% of individuals infected are called non-progressors, so they have HIV, but it never develops into the more advanced form called acquired immunodeficiency syndrome, or AIDS. So they have HIV, but they never develop AIDS. So if HIV is left untreated, it will turn into AIDS. One of the hallmarks of AIDS is opportunistic infections with pathogens that in a person with normal immune system would not be causing problems, but in HIV, which destroys a lot of the immune cells, we have microbes can cause disease where normally they wouldn't in a healthy person. Modes of transmission, direct contact. So body fluids that have the highest number of virus are sex fluids, blood, and breast milk. So things like saliva and sweat have very small numbers of virus particles, so they cannot be infectious. Parenteral, so if you share needles with a person infected with HIV as intravenous drug users do, then this can be a way of transmitting the virus. And its virulence factors are its ability to go latent, so it can insert DNA and then the virus is amplified in the host without any signs or symptoms of infection. So initially, the virus enters through mucous membranes, either in the urogenital system, or if we have parenteral transmission, we can enter through tissues lining the vessel. Cells infected are dendritic cells, macrophages, which are two types of phagocytes, B cells, and T cells. There's several signs or symptoms, and diagnosis is going to be by two markers. So first, a person has to test positive in their blood plasma or serum for HIV antibodies. Second, they have to have either a T cell count below 200 cells per microliter, or T cells have to be less than 14% of their total B and T cells, or they have to have an AIDS-defining illness. And I'll show you a list of those in a moment. These are the opportunistic infections that we see in HIV patients and not in healthy patients with normal immune systems. Okay, and we'll talk about prevention and treatment in a moment. So this is a figure from your book showing HIV. So things I want to point out are the RNA genome, the presence of an enzyme in the virus, which a lot of viruses don't have their own enzymes. They just use host cell enzymes, but HIV has its own reverse transcriptase, which is an enzyme that can make DNA from RNA. So what it does is it will copy, once the virus gets into a host cell, reverse transcriptase will make a copy of the RNA genome into DNA, and that DNA will then be integrated into the host genome using another enzyme that HIV has called integrase. So integrase will make a cut in the host cell DNA and insert the RNA virus DNA copy into the host cell DNA so that the host cell now has the virus, provirus, present in its genome. HIV is also surrounded by an envelope, and it has spikes which help in adherence to host cells. So the spikes shown in the detailed zoomed in drawing will bind to CD4 and CCR5 receptors on the surface of host cells for HIV. And one of the things in some non-progressors is it's been found that certain individuals can have mutations in their CCR5 receptor so that the HIV spikes can't bind and therefore can't infect host cells. So the person, although has HIV, will never develop into AIDS. This is a list of AIDS-defining illnesses, or ADIs. So most of these are opportunistic infections which in a normal person with a healthy immune system would not lead to disease, but because people with HIV have repressed immunity because the virus infects lymphocytes and phagocytes and destroys them, the immune system doesn't respond very well. So microbes that normally don't cause a problem can become pathogenic for a person with HIV. And this is a picture of one of them. This is Kaposi's sarcoma. So it's an incredibly rare form of skin cancer, and it is an opportunistic infection that's often associated with HIV infection. Another one that's really commonly associated with HIV infection is tuberculosis. Okay, this chart shows the progression of HIV through 4 stages, and this is the progression of HIV in the absence of medical intervention. So if the person does not take any antiviral drugs or have any intervention by a physician or a medical treatment, then this is how HIV would progress. So we have the y-axis labeled with concentration of blood component, so we're looking at the level of 3 different things in the blood. And the x-axis is labeled with time, and we have time divided into 4 phases of the infection. Okay, then we have a green line which shows the level of virus antigen, so this is how much virus is present in the blood. The orange line is the level of antibodies to HIV, so this orange line indicates the immune response of the host. And the purple line is the level of CD4 T cells, which is one of the host cells of the virus that becomes destroyed as the infection progresses. So initially we have infection at time 0, and we see a big jump in the level of virus antigen with the green line initially. So this is one of the points when the amount of virus is highest in the host. We see the orange line representing the response to the HIV infection. So initially we have very little response because the B and T cells are becoming activated against the antigen and starting to produce antibodies. So it takes a couple of weeks before the immune response to the virus is really at a high level. And then in the purple line, we see the starting level of T cells in the blood. So normally we should have more than 500 T cells per milliliter of blood. In the first phase of infection, we often have very minimal symptoms. They may be kind of like mono, where you have swollen lymph nodes, but nothing more. Phase 2 is indicated by a drop in the level of virus antigen in the blood, and this is because most of the virus particles have gotten into a host cell and have inserted their DNA. So we have very little free-floating virus in the blood in phase 2. Most of the virus is now in a host cell. We see also in phase 2 an increase in the level of antibodies, so the immune system is trying hard to fight the virus infection. And we start to see a decrease in the level of CD4 T cells, which are being destroyed as they're being infected by HIV, which will then burst the cell and go on to infect other host cells. Phase 3 is a really long period, which is mostly asymptomatic. You can have small signs or symptoms like swollen lymph nodes. We see in this phase a very low level of virus antigen in the blood because all virus is inside a host cell. We see a continued effort by the immune system to make antibodies to fight the infection, and we see a steady decrease in the level of CD4 T cells as the number of host cells infected becomes greater. In phase 4, we are now considered having AIDS, so HIV has progressed to AIDS. We have fallen below the critical level of 200 T cells per milliliter of blood. We continue to see production of antibodies, although at this point the immune system is largely non-functional. So although antibodies are present, they aren't able to do very much to fight the virus. And then the green line shows that the level of virus antigen starts to go up as it leaves host cells, and we see a massive infection of all of its host cells, and so there's a lot of virus present in the blood. Diagnosing HIV can take up to 3 months because it takes a while for antibodies to be produced at a level that can be detected. There's now a over-the-counter way to detect the presence of HIV antibodies by something called ELISA, which is the same thing that's used in pregnancy tests. So you simply do a mouth swab, and then the presence of 2 lines indicates positive for HIV, where C is a control line and T would be the antigen line. This is sold over the counter. It has a tendency to have false positives or false negatives, so it's recommended that individuals go to a healthcare office to get tested as well. But it's thought that having this available to people can help identify individuals that are infected that don't know it. There are also ways to test plasma viral load. So this looks for the RNA genome of HIV, and these can be done within 7 to 10 days of infection. So this is usually used in cases of blood transfusion or organ donation to determine if the blood or organ is infected with HIV, because if it's been less than 3 months, you can't detect by antibodies. So the PCR is used in those cases. And that concludes chapter 20.